Before we dive in, a quick request. Please subscribe, like this episode, and drop your next community medicine topic in the comments. Your ideas shape what we cover next. Welcome back, everyone. Today's exam-focused episode tackles emerging and re-emerging diseases, why they keep surprising us, how to recognize the drivers, and what modern public health actually does about them. Guiding us is community medicine specialist Dr. Joshi.
Delighted to be here.
Let's open with the problem statement. Dr. Joshi, what do you mean by a crisis of complacency?
For a few decades, there was optimism that infectious diseases were largely solved with antibiotics and vaccines. That optimism slipped into complacency, underinvestment in surveillance, laboratories, and workforce, which the world has paid for in repeated outbreaks. Disease patterns are dynamic. Every decade writes a new chapter. When something novel appears, epidemiology is usually the first scientific method applied. We describe person, place, time, generate hypotheses on sources and transmission, and guide the response.
Definitions are Viva gold. Could you define emerging and re-emerging infections with examples?
Emerging infectious diseases are infections whose incidence in humans has increased in the past 2 decades or threatens to increase in the near future. They include new diseases and those spreading to new regions. Classic examples: severe acute respiratory syndrome, H5N1 avian influenza, COVID-19, HIV/AIDS, Ebola virus disease, and Lyme disease. Importantly, most emerging events are zoonosis, animal origin, about 60%, and a majority of those begin in wildlife. Re-emerging infections are diseases that return after a decline, often driven by antimicrobial resistance or weakened health systems. Examples to remember: multi-drug resistant or MDR tuberculosis, resurgent malaria in certain eras and areas, cholera in explosive outbreaks, and plague in episodic clusters.
The outline also mentions non-infectious emerging concerns. How do you connect those?
Population-level shifts like epidemic overweight and obesity emerge from changes in diet and physical inactivity and drive type 2 diabetes and other chronic diseases. For exams, frame them as emerging public health threats, distinct from microbes but managed with population-wide prevention.
Why do these threats emerge or resurge? Let's organize the drivers.
Think in 3 baskets: environment, microbes and systems, and people. First, ecological and environmental change. Rapid population growth pushes human activity into forests and wildlife interfaces. Land use shifts like deforestation, urban sprawl, and agricultural intensification create new contact networks. A classic example: the Nipah virus spillover linked to fruit bats, pig farms, and orchards. How we rearrange landscapes alters pathogen pathways. Climate variability can extend vector ranges or shift seasonality. Warmer temperatures can accelerate vector breeding and pathogen replication. Second, microbial evolution and health system failures. Antimicrobial resistance shrinks our treatment options. Insecticide resistance blunts vector control. Weak sanitation, poor labs, and delayed reporting allow outbreaks to spread before they are seen. Third, social and behavioral factors. Fast global travel turns a local spark into an international fire within hours. Behaviors such as substance use, multiple partners without protection, or even changes in animal trade reshape risk. Add the persistent concern of bioterrorism, intentional release of agents, and you have a complex risk landscape.
Case Vignette 1 for application. A district hospital sees an unusual cluster. Adults with high fever, severe myalgia, and bleeding gums over 3 days. No travel history. What's your first public health move?
Activate surveillance and verification immediately. Notify the district surveillance unit, collect standardized line list data, secure specimens with biosafety, and alert the state lab. Simultaneously begin infection prevention, risk communication, and rapid environmental assessment. In India, this is the bread and butter of the Integrated Disease Surveillance Program, spelled IDSP, which captures SP and L forms weekly and flags early warning signals for epidemic-prone diseases. Newer platforms like the Integrated Health Information Platform, or IHIP, aim for near real-time case-based reporting and geospatial dashboards.
That takes us to strategies. Start with surveillance as the foundation.
Surveillance is continuous systematic collection, analysis, and interpretation of data linked to action. We track baseline rates to detect aberrations and issue alerts. In India, IDSP units collate weekly trends and investigate spikes. IHIP adds digital case-based layers in event alerts, including mobile data entry for S-form community reports. Early warning is not just numbers, media scanning and unusual syndrome, for example respiratory distress or hemorrhagic fevers, also feed the system.
The outline calls this the need for speed. What's new about rapid detection?
Two things. First, event-based surveillance, we pick up signals before lab confirmation. Second, digital exhaust. Researchers have shown that aggregated online search queries can correlate with influenza-like illness, illustrating how non-traditional data streams can sharpen early detection when used alongside classic systems. The exam-ready line is, use traditional surveillance plus complementary digital sources, never one in isolation.
The next pillar is the One Health approach. Give us the crisp definition and why it matters.
One Health is an integrated, unifying approach that balances and optimizes the health of people, animals, and ecosystems. It recognizes that human, domestic, and wild animal, plant, and environmental health are interdependent. That is why outbreak teams increasingly include clinicians, veterinarians, wildlife experts, entomologists, and environmental scientists.
Any named program students can quote?
Yes. A classic example is PREDICT, a global effort that worked in hotspot regions to detect high-risk viruses in wildlife and understand spillover routes, illustrating operational One Health surveillance across bats, rodents, primates, and human interfaces. You can cite it as a prototype of early warning systems at the human-animal environment interface.
Case Vignette 2. A 28-year-old traveler returns from a rainforest trek with fever and rash. The emergency unit wonders, dengue, chikungunya, or measles. How do you apply today's framework?
Use epidemiology first. Onset date, travel itinerary, exposures, vaccination status, insect bites, animal contact. Classify by syndrome, acute febrile rash illness, and take infection control precautions. Notify surveillance if the case is unusual or clustered. Arrange appropriate tests, but do not wait to trigger public health actions, contact tracing, vector control, and risk communication as indicated by the working diagnosis.
Zooming out, how do we tie prevention and control together for a long answer question?
Structure it like this. 1. Strengthen host defenses, vaccination where available, good nutrition, and protecting high-risk groups. 2. Break transmission, sanitation, safe water, vector control, respiratory etiquette, and standard precautions in healthcare. 3. Surveillance to action. Maintain IDSP or IHIP reporting, event-based alerts, and district rapid response teams. Ensure timely specimen transport and lab confirmation. 4. Risk communication. Clear, timely, and empathetic messaging prevents panic and guides care seeking. 5. One Health and intersectoral coordination. Map veterinary, wildlife, agriculture, environment, and urban agencies into your outbreak plan. 6. Antimicrobial stewardship and vector control resistance management. Use standard treatment guidelines, rotate insecticides as per entomological surveillance. 7. Research and innovation. Support new diagnostics, drugs, and vaccines. Evaluate real-time analytics and climate-linked early warning models.
Quick self-checks for active recall. Ready?
Sure. Pause and recall. What is the operational definition of an emerging infection? Answer: incidence increased in the last 2 decades or threatens to increase soon. Pause and recall. What proportion of emerging events are zoonotic and where do most originate? Answer: approximately 60% zoonotic and many from wildlife. Pause and recall. Name India's digital upgrade of IDSP for near real-time case-based surveillance. Answer: IHIP. Pause and recall. One sentence defining One Health. Answer: an integrated approach linking human, animal, and ecosystem health.
Students often ask, how do I write about climate and land use without sounding vague?
Use a cause chain. Example: deforestation and agricultural expansion change wildlife movement, bats feed at farm orchards, livestock like pigs become amplifiers, humans working or living nearby are exposed, increasing spillover risk. That is a concrete, exam-worthy explanation rooted in land use change.
Let's finish with a focused conclusion and action items.
Big picture are strategies shifting from a simplistic war on microbes to intelligent coexistence. Predict, Prevent, detect early, and respond fast. Practically, that means keep immunization strong, invest in water, sanitation, and hygiene, run robust surveillance that links numbers to action, and embed One Health teams for zoonotic risks. For students on postings, learn your district's IDSP or IHIP logins and reporting flow, know your rapid response team contact, and practice a clean outbreak line list. And remember, innovation matters. Better diagnostics, drugs, and vaccines, plus ethical use of digital signals alongside classical epidemiology will decide how well we face the next emergence.
Perfect wrap. If this helped your revision, subscribe, like, and suggest the next topic. Maybe outbreak investigation steps or risk communication in emergencies. See you in the next episode.